Chest pain. What is the chiropractor's role? It may appear outside the usual scope of practice for a chiropractor to deal with a patient complaint of chest pain if one assumes all chest pain is cardiac. Remember, though, that patients are self-selecting and will not usually seek chiropractic management if they believe they have something cardiac or something viscerally serious. For that reason, insidious onset of chest pain will steer individuals to medical evaluation. It is more common then that patients would only ask their chiropractor for advice when not given a diagnosis for their chest pain by their medical doctor. Certainly, from a risk prevention approach, all chest pain should be assumed cardiac until appropriate evaluation indicates otherwise. What are those indicators, and what actually happens to those who do not have a cardiac explanation for their chest pain? You may be surprised. Up to 50% of patients with chest pain have a non-cardiac cause, with 13 to 30% being musculoskeletal. Recurrent episodes of pain are estimated to affect 50 to 90% of patients with non-cardiac chest pain. Even though patients are told that they don't have a cardiac disease, only 30 to 50% feel reassured, and as many as 50% remain on cardiac medication, and 75% continue seeing a physician. In an emergency room setting, acute chest pain requires investigation for acute coronary syndrome. However, acute coronary syndrome represents only about 5 to 6% of all admissions to emergency departments in Europe and the United States. And only 20 to 25% of admissions for chest pain to the ER are caused by ACS. Patients with chest pain who receive no definitive diagnosis account for approximately 20% of admissions for suspected ACS. So what is acute coronary syndrome? Let's start with what it isn't. Acute coronary syndrome is not stable angina. The diagnosis of acute coronary syndrome is based on EKG and biomarker findings including CPK and troponin T, which indicates either or both cardiac ischemia and damage. ACS is usually one of three diseases affecting the coronary arteries: ST elevation MI, accounting for 30%, non-ST elevation MI, accounting for 25%, and unstable angina, accounting for 38%. As a reminder, ST elevation on EKG indicates severe ischemia often associated with myocardial infarction. In the United States, for patients suspected of having ACS but who are found not to have coronary artery disease, it costs approximately $8 billion for their initial care, even without a definite diagnosis or plausible explanation for their chest pain. With this background, let's begin a discussion of how chiropractors might integrate into the management of chest pain. First, let me introduce you to two studies that have addressed this issue. We'll cover the first one briefly before spending more time reviewing the more recent publication in 2012. The first publication is entitled Manual Therapy for Patients with Stable Angina Pectoris, a non-randomized, open prospective trial by Christensen et al. Published in the Journal of Manipulative and Physiological Therapeutics in 2005. In this study, 275 patients referred for coronary angiography with no evidence of cardiac involvement were then divided into cervicothoracic angina positive or negative. What is this designation? Patients who were negative on angiography were evaluated using motion palpation, palpation of the chest for tenderness, and prone palpation for restriction and tenderness from T1 through T8. Those with findings were considered CTA positive, those not, CTA negative. All were then treated chiropractically over a 1-month period and evaluated for change. "75% of the CTA-positive individuals reported improvement in pain and general health, whereas 22 to 25% of the CTA-negative group reported improvement. Whereas pain intensity improved in both groups, SF36 changes were found only in the CTA-positive group. Although not a strong study scientifically due to the non-randomization and non-blinding and the lack of control for confounding elements, it was a good start. In the more recent publication, the focus of this presentation, the study involved individuals without ACS entitled Chiropractic Treatment versus Self-Management in Patients with Acute Chest Pain, a randomized controlled trial of patients without acute coronary syndrome by Stock-Kendall and Christensen et al., published in the Journal of Manipulative and Physiological Therapeutics in 2012. First, to better understand the study, let's run through a quick overview of the differences between cardiac and non-cardiac chest pain. For cardiac causes, discomfort is often described not as pain, but pressure, squeezing, or crushing. It's usually diffuse, and the location is substernal or precordial, meaning over the heart. The pain may radiate to the arm or to the jaw. It's often exertion-related, lasting on average 10 to 30 minutes. Non-cardiac causes extend across many areas, including musculoskeletal and visceral, so that pain may be brief to continuous. The pain is often localized. However, radiation can occur, but is uncommon unless along a rib. It's often reproducible if neuromusculoskeletal. However, organ-referred pain is not usually reproducible. Let's look at why cardiac pain has these characteristics. Here we can see why it is diffuse and can overlap with other causes. The innervation for pain is from visceral afferents, part of the sympathetic nervous system. Overlap with organs include the lungs, esophagus, and upper GI. One of the most common mimickers of cardiac pain is in fact esophageal. Making this even more diffuse and overlapping is the communication through the cervical chain ganglia and axons from the upper thoracic spine. This may have overlapping effects with somatic innervation with the phenomenon of radiating or referred pain. Referred pain to the arm is not related to the somatic innervation through the brachial plexus, but through the sympathetic innervation. Note that the sympathetic supply to the arm is from T1 to T6 on average. Jaw pain, similarly, is the relationship through the sympathetic nervous system between the upper cervical ganglion and specifically C2. Remember that the cranial nerve 5 sensory innervation of the jaw is to the beard line of the jaw, whereas C2 is for under the jaw, more often where radiating or referred pain is felt. For non-cardiac chest pain, there are many causes, the most common being herpes zoster. Muscular involvement is usually through strain or trigger points. Strains can be evaluated through contraction and stretch of the chest muscles, such as the pectoralis major and minor, intercostals, and the serratus anterior. Here's an example of various maneuvers that can be used to challenge the chest muscles through stretch, compression, and contraction. Medical evaluation for chest pain rarely considers this approach. It's important that if pain is created or exacerbated, the doctor must confirm that this is the same pain the patient is complaining of. Trigger point involvement is identified through a reference zone of pain for each individual muscle and possible pain produced at end-range stretch. Here are a few common trigger points. Note that X marks the trigger point with the darker areas the referral zones. Note the similar combination of chest pain with arm pain with many of these presentations. Here are other common causes of chest pain. Certainly, rib pain is often traumatic or overuse in cause and more easily distinguished. Not so obvious sometimes is referral from facet joint involvement of the thoracic and cervical spine. Interestingly, for at least 30 years, it's been recognized that the cervical spine can mimic cardiac pain in a condition called cervical angina, referring specifically to the referred pain from a degenerated cervical spine in older patients. Certainly one of the more common mimickers are esophageal spasm and GI reflux. One study indicated that as many as 80% of individuals with esophageal spasm as the cause were misdiagnosed with angina. Why? Because esophageal spasm responds to treatment with nitro, and because it is substernal, it seems very similar to the presentations of angina. So how can you tell the difference? Here's a table with the percentage of individuals in either the esophageal or cardiac group matched to a presenting sign or symptom. Notice that many patients with cardiac involvement do have GI symptoms, but as you go down the esophageal list, you'll see that in descending order, these are findings predominantly in esophageal patients. Now on to angina. There are three types of angina. Stable angina is due to atherosclerosis. It's exertion-related, usually lasting less than 10 minutes. It's improved with rest and nitro. There is ST depression on EKG, but negative findings for cardiac enzymes. With unstable and Prinzmetal's angina, although the presentation may be similar, the cause is different. The pain occurs at rest, lasting longer than 10 minutes. Nitro usually helps. ST depression or elevation are usually found on EKG. Unstable angina, though, is due to complicated atherosclerosis, meaning that plaque fractures and bleeds, whereas Prinzmetal's is due to vasospasm of the coronary arteries, seen more often in younger females. So what are the historical clues for MI? Here's a descending list based on a positive likelihood ratio. Remember, this means that a high positive likelihood ratio is great for rule in, but unfortunately it does not necessarily have value as a rule out. For example, radiation into both arms is not a common finding, so it is not used to rule out if not present. When present, though, it has a high diagnostic rule in value. For the confirmation of MI, the following are needed. Increasing levels of biomarkers such as troponin T and CPK in the early phases. EKG changes include axis deviation away from the damaged area, significant Q waves, and ST depression or elevation. It's also been found that these findings are valuable in the prediction of future events. Now on to how participants qualified for the current study. Patients presented to the ER with acute chest pain. They were evaluated with EKG, CPK, and troponin T. If there was a definitive diagnosis of cardiac involvement, they received medical care. Those that did not have a definitive diagnosis were referred for participation in this study. The patient selection involved the following inclusion-exclusion criteria. For inclusion, patients were ages 18 to 75, had a primary complaint of acute chest pain for less than 7 days, were a local resident who understood Danish, and had undergone diagnostic procedures to rule out ACS. They also had no significant contraindications for spinal manipulative therapy. Exclusion criteria were any previous diagnosis of ACS, any prior coronary interventions or coronary artery bypass, and a number of other complicating diseases and disabilities. Participants were then assigned to one of two conservative treatment approaches. One group involved chiropractic treatment, including spinal manipulation using a high-velocity, low-amplitude adjusting of the thoracic and cervical spine. The other group was directed to self-management, indirectly serving as a control group, potentially illustrating natural history, given there was no specific therapy for the chest pain itself. For the chiropractic group, high-velocity, low-amplitude manipulation was combined with any of the following: joint mobilization, soft tissue techniques, stretching, stabilizing or strengthening exercises, heat or cold, or advice. A maximum of 10 treatment sessions of approximately 20 minutes duration occurred. Treatment 1 to 3 times per week for 4 weeks was allowed. There were 57 participants in this group who completed the treatment course and were on average seen 7 times. The areas most often treated were the mid-thoracic region, T4 through T6, and the lower cervical spine, C6 and C7. Trigger point therapy and massage were the second most commonly used treatments. For the self-management group, there was a 15-minute consultation consisting of reassurance and advice directed toward promoting self-management. Individuals were told that their chest pain generally had a benign, self-limiting course. They were given individual instructions regarding posture and were given 2 to 3 home exercises for increasing spinal mobility and stretch. They were told to seek medical attention if either a severe or unfamiliar chest pain occurred, and to refrain from seeking any type of manual treatment directed toward the muscles and joints of the thorax for the following 4 weeks. There were 2 primary outcome measures. Based on an 11-point numerical pain scale, the first was change in pain intensity from baseline to follow-up. They were asked to, quote, rate your worst chest pain during the last 7 days, unquote. And secondly, self-perceived change in chest pain at follow-up, asking, quote, how is your chest pain now compared with what it was before you received treatment in this study, unquote. Using a 7-point ordinal scale response, categories ranged from much worse to much better, with the category unchanged in the middle. Secondary measures included SF-36 scores with 5 measures of change in pain intensity, self-perceived change in general health, and self-perceived effective treatment. Effectiveness was assessed by questionnaires at 4 and 12 weeks after randomization. The results? At 4 and 12 weeks in both groups, the reduction in the number of patients with worst chest pain was statistically significant when compared with baseline. At both 4 and 12 weeks, the largest decrease in worst chest pain was seen in the chiropractic treatment group. However, the improvement did not demonstrate significant differences between groups. So as usual, let's discuss the weaknesses and strengths of this study. Weaknesses were that the researchers did not meet sample size required for this study. Gastroesophageal reflux and other common causes were not ruled out. Follow-up was short-term, and there was no comparison to, quote, usual medical care, unquote. Strengths were that this was an RCT. This was a collaborative study with medical doctors willing to see what chiropractic management may have to offer to this group of patients. The protocol used to assess patients for possible spinal and muscular involvement might be of practical use in practice. So what can we clinically harvest from these results? It might be implied that over a 12-week period, participants did show improvement, but we don't know how that would have compared to those under usual medical care. Using the current literature, it appears that either approach, chiropractic or self-management, is likely more cost-effective and with fewer risks and complications. What we don't know is how long these results last. And finally, we can't conclude anything about the contribution of manipulative need and etiology of pain for patients with a non-cardiac cause. However, this is a great example of collaborative research that can only be conducted with the involvement of medical doctors and hopefully paves the way for more similar research. Remember that chiropractors can serve a safety net role of screening for those with a possible cardiac cause of chest pain and refer for appropriate evaluation and management. And for those without a cardiac cause, we may provide an effective approach for musculoskeletal sources of pain.